Okay, first I'm going to start with observation. I'm going to look for any scars, any pimples, or anything that would mess up with the nervous scope. And I'm also going to look for any visible edema. And I see a little bit right here and a little bit down here. Next, I'm going to get the instrumentation. I'm going to turn it on and set it to medium. And I'm going to close the probes. And I'm going to start at approximately T1, T2, and I'm going to move up the cervical spine. And I'm going to look for any break. And if I find a break, I'm going to mark below the nervous scope. So find here, and I'm going to move up. I'll make sure that I stay 90 degrees to the skin and the spine, and I want a little bit of dimpling to make a good seal. If I do find a break, I'm going to scan over it 3 more times to make sure that it actually is a break, and I'm going to mark the side that it breaks to underneath. Then I'm going to go down the spine. I'm going to do the same thing, but first I need to open it as wide as possible. I'm going to move down, make sure there's a dimpling, 90 degrees. And I'm going to look for the break. If I do find one, I'm going to scan over it 3 more times and then mark above. Okay. Then I'm going to look and palpate, see if there's any bogging down of the tissue. And right here, it's kind of bogging down. That's looking for edema. And I'm going to ask the patient if any of this is tender. And then I'm going to touch the bottom of the spinuses and ask them if any of those are tender at the areas I found the breaks. And up here. Next, I'm going to do motion palpation of the thoracics. So I'm going to start with 2 fingers on the spinuses, and I'm going to ask the patient to extend backwards. Extend your back, like push your back into my fingers. Push back into my fingers, like arch your back. There you go. And back up, and then do it again. And I'm looking to see that they separate. And if they don't, then it's posterior. Then I'm going to have them rotate. And I want these spinuses to separate. If they don't separate, then the side that I rotated them to is the side that has the restriction. So I have a posterior spinous because they did not separate, and then separating upon rotation on right, so I have a PR. And then I'm going to have them flex, and that's testing for the wedge. And I want to feel a curve. If I don't feel a curve, that's the side of the wedge, and that's a PR, and it's also, well, that's a left rotation. So it's a PL, and it's on the same side, so it's a PLS. Next, I'm going to assess the SI joints. I'm going to have stand on the opposite side of the joint I'm assessing. I'm going to have 1 finger on the PSIS and 1 finger on the sacrum. I'm going to rotate them on the ipsilateral side. I'm looking for any motion. If there isn't motion, that's the side I'm concerned with. Let's assume that it's the right side. And then I'm going to have the patient stand up. Can you stand up for me, patient? And since this is the side I'm concerned with, the right, I'm going to put 1 finger on the PSIS, or actually 1 thumb on the PSIS and 1 thumb on the sacrum, and I'm going to have them lift the same side knee as if marching. And I want the PSIS to move back inferior, and then I'm having them lift the opposite side, and I want the sacrum to move inferior. If the ilium doesn't move posterior, then that's on the same side, then I have a AS. If it doesn't move on the opposite side, then I have a PS. So right now I have a right AS. And then I'm going to have look for the glute width. to see if it's internally or externally rotated. And I see that on the right side, which is the side I'm concerned with, it's a little bit wider, so I know that it's internally rotated.